It gives me great pleasure to introduce Dr. Alan N. Lewis to the stage. Dr. Lewis is currently the Dean and Professor of the College of Health-Related Professions at SUNY, and he's going to present to us. What you will notice is that there are some tools up here. You can do all of your pointing and advancing of slides right here. Okay? Thank you.
Good morning. So the first thing you see is there's a picture. I love visuals. A fellow wrote a book in 1969 by the name of Rudolf Arnheim called Visual Thinking. He's deceased now, died in 2007, was a perceptual psychologist, and he made the argument that for those of us who are sighted, excluding those who've never seen, we tend to think and recall in pictures. And I sort of follow his thinking on that. So my comments will be primarily based on this one visual. And of course, my charge this morning is to talk about adherence, patient adherence, from somewhat of a conceptual point of view, and to unpack some of the inherent challenges. And this is not an all-inclusive diagram. It just includes the things that sort of naturally occur to me as potential challenges when we're trying to talk about the whole phenomenon of having patients adhere to the advice that a provider gives him or her. So the goal, obviously, is concordance between the patient and provider on what needs to happen. So there's agreement. There should be agreement between the patient and provider on what needs to happen. And then the big piece is that the patient needs to follow up on that agreement by demonstrating some action. And we know that sounds good. It doesn't always happen, and these are some of the reasons why. So look at the very top of the diagram, imperfect communication. I'm going to start there. Now, when I think about imperfect communication, it takes me back to when I used to be a student of communication back years ago as an undergrad. And there's something called the basic communication model. It's not on this picture, but the basic communication model is this. All interpersonal communication starts with a sender of a message. The message travels from that sender to a receiver. So it's sender, receiver, and a message between, right? And then the message goes back and forth as it's heard and feedback is given. A really basic model. That should work perfectly, right? Not a lot of moving parts. Sender, receiver, and a message. Well, we know that that model is flawed. Why is it flawed? I'm a communicator this morning. I'm delivering a message to you. Everything about how that message is constructed is a product of me, consciously and subconsciously. It's all about me and my cultural orientation. So it gets constructed in a way that's unique to me. Dr. Salafu would construct it differently because he's a different person. It travels to you. You hear it, not necessarily the way that I intended you to hear it or how I constructed it. It goes through a filter called you, and you hear it based on who you are, based on your life experiences, the sum total of your subjective realities, everything about who you are. So although it seems like a very direct and easy process that should go well 99% of the time, we know that's not the case. Because as the message leaves me, it's all about me, even though I think I'm being very clear in how I'm articulating what that message is. And as it lands where you are and you hear it, it's all about what you hear and what you perceive, and that's all about who you are. And because we're two different people with two very different subjective realities, the process is never perfect. So the first part of patient adherence obviously is a provider communicating with the patient about what that activity is that needs to happen, that if it happens would equal compliance. So we know the first weakness or the first noise in the model is that the communication is never perfect. Although the basic communication model might lead us to think that it's a pretty basic process, it never is. Okay, moving over to differential expectations. Expectations also are very unique to people. There's the basic nature of an expectation. I'll give you an example. So say that I'm talking to my provider, my healthcare provider, and this is close to reality. And she tells me, Alan, I want you to change your diet, and I want you to start eating fewer carbohydrates, less salt, less sugar, clean up your eating habits. And okay, so here we are, November 4th, and I'm thinking, okay, that sounds great. So the nature of that expectation, she wants me to do it 100%. And And I'm thinking, okay, I may not do it 100%, but if I clean my diet up some and eat less sugar, maybe eat as much salt as I want, or eat less salt and as much sugar as I want, then that will at least help me, right? I'm moving in the right direction. So right off the bat, there's a difference in the basic nature of the expectation. My provider's expecting 100% compliance, and I've already watered it down to something less than 100%. So the basic nature of the expectation may be different, and then the implementation can also be different. So I may decide, well, it's, again, November 4th, Thanksgiving's almost here, the winter holidays are almost here. I'm not really going to start that new eating routine until January 15th, so I can get through the holiday season and have fun. And my provider's thinking, no, you need to start now. But we don't necessarily communicate that in a very explicit way. So she doesn't know that, and I'm already planning to, I'm going to improve my diet after Christmas, after the winter holidays. So the implementation is not 100% on target. She thinks it's more immediate, and that I'm going to do it 100%. I'm thinking I'm going to do it 75% of what she wants me to do, and I'm not going to start till 2 or 3 months from now. So the expectations are very different. So not only is the communication flawed, because that basic model, although it leads us to think it can be perfect, never really is, because we're talking about two very different individuals. The expectations can be very different, both in terms of the basic nature of the expectation, how much I'm going to actually comply, and how I'm going to implement that. Whether I'm going to do it immediately, or phase it in over time, or not even start it until some undetermined time, or maybe some specific time down the road. If that were not enough, we have worldview differences. Edwin Nichols wrote a piece in 1989 called The Philosophical Aspects of Cultural Difference. And he's a psychologist out of Washington, D.C., and I think he's still alive. He's probably about 100 years old now. He devoted his life's work to traveling the world and understanding and basically documenting that there are differences in worldview based on cultural orientation. And some people say, well, we make too much out of these differences. We're all just human beings, so we're pretty much the same. His point was, no, not really. So if you ever look at his work, you'll see that what he's done is he's taken philosophical aspects such as axiology, that which has value, epistemology, how we come to know things, logic, and several others. He looks at pedagogy, how we teach, those kinds of things. And those are the philosophical aspects, and he shows how different groups around the world, defined by culture, approach those philosophical processes differently. And so he basically confirms that there are differences in worldview based on cultural orientation. So I would encourage you to take a look at his work, 1989, Edwin Nichols. But what that tells us is that there are differences in perspective, differences in worldview, differences in subjective reality, which is the sum total of your experiences as a human being. And the things that we value, the assumptions we make about things, the stereotypes we have, the values that we hold near and dear, how we come to know, the logic that we employ in situations, how we arrive at conclusions or how we construct arguments, the logical thinking can be very different. And so sometimes in a situation with a patient and provider, there's a difference in what's valued. The values are different. How one comes to know what's important. A patient may think, okay, it's important that I begin to do this at some point or do some of this, but maybe not as important to do all of it. So how we come to know that is different based on our cultural orientation. So oftentimes there are perspective differences, point of view differences, are also known as worldview differences, that are significant, that speak to why patients and providers don't always have the same exact vantage point on what that adherence needs to be going forward. And perhaps the biggest area that's difficult for us to deal with, and I know this is something that that's difficult because we don't always have time in a traditional medical setting to address what I call the individual change model. So what happens is we don't typically address those steps for sustained action that need to be addressed to ensure that somebody will actually do something different. So when a patient comes to a physician or another healthcare provider, occupational therapist from my school, physical therapist, whoever it may be, you're asking them to do something different. You're prescribing a protocol, some intervention, some strategy that's going to result in some improved outcome. That's a change. The person's not doing that already, so you're really asking that person to engage in a change process. And we know that change is very difficult. At the individual level, we know that there's several phases, several components that need to be in place for this change to happen and be sustained. And I submit that these 5 steps, or these 5 stages, are what we need to think about when doing that. So the first thing is you have to have knowledge or awareness that there's a need for change. And I'll use myself again. So I know that eating fast food is not good for you, it's not healthy. I like fast food. But I know that eating fast food is not healthy, right? Most of us know that. So the knowledge and the awareness is there. So my physician may tell me, okay, Alan, eat a little bit less fast food or stop it altogether. So the first piece is satisfied. Knowledge and awareness. I know it's not good for people to eat that kind of food. Understanding. Understanding is taking that knowledge or that awareness and moving it to the personal level and applying it to me. So I can't just say in a general way, yes, eating at McDonald's 3 times a week is not good for people. I've got to recognize that Alan eating at McDonald's 3 times a week is not good for Alan. So it moves from just being general awareness and understanding, education, knowledge, to it being something that applies specifically to me. That's where the understanding comes in. It's applicable to me. And then I've got to have some motivation to change. And we know from the motivational interviewing literature, and I'm a counselor by profession, that motivation is something that's inherent to the person who has to make the change. You can't impose motivation from the outside, although we've tried that for decades in various ways. So we know that in a motivational interviewing counseling situation, the way that people find their own motivation, which is what has to happen, is that you create an environment of dissonance, a conflict between what they say they want to do and what's happening right now in their life. And eventually, if you create that dissonance strong enough, the person looks for a way to resolve that dissonance, and therein becomes the motivation that's unique to that person. So you've got to find a way to have that motivation be specific to the individual in a way that they will actually move forward on that knowledge and understanding that they now have. And then to actually move forward, I may be motivated to not eat fast food, but in order to not eat fast food, I need different skills. I need some decision-making skills. I need skills to refuse the impulse to eat. I need skills to choose better options of what I can eat. Those are new skills that I may or may not have. How do you have new skills? How do you develop new skills? You don't just tell me, Alan, make a different decision. How do people develop new skills? Practice. You've got to do some role plays. You've got to do some situationals. You've got to practice. So those skills have to be developed. We're not developing those skills and we're asking people to adhere to things. We're just saying, go do it. There's no discussion of, can you do this? Do you have the wherewithal? Do you have the self-efficacy? Do you have the ability to do this? So that's the skill piece. And then the context has got to support that new behavior. Years ago, I used to work in drug rehab, and we used to have people come in and we'd fix the person totally, send them right back to the same social, cultural, home, neighborhood environment, and guess what? That change that they had embodied quickly went away because there was no context support for the new behavior. So we've got to think about what things can be put in place, or how can we address at least having a conversation about what the supports need to be in that patient's environment so that that adherence can have a chance of actually happening. So I submit that these 5 steps, and I know our time is limited in our encounters, but these 5 steps don't get addressed fully. If we could address them, I think we'd see a lot more adherence in the things that we want patients to do. Got to have the basic knowledge, got to attach it to themselves in terms of understanding, got to have the motivation that says I'm going to actually do this, got to have some skill that allows the new behavior to actually manifest itself, and then I've got to have some support in my natural in vivo environment to allow that to happen. And we fall way short of having this process play out, primarily because there's not enough time, but we also don't think about it in this kind of a stepwise, sequential way. But this is what needs to happen for sustained new action to actually begin and continue over the long haul. So these are just 4 of the areas that are inherent barriers or challenges to patient adherence. The communication is flawed, expectations are not lined up between the patient and provider, there's a difference in worldview or perspective because of things like axiology, epistemology, and logic and other philosophical aspects. And then we don't often address the change process in a comprehensive and systematic way to ensure that when we ask somebody to do something differently, that they have a reasonable chance of actually getting that done. It's easy to say do it, but much more challenging to say, okay, here's what we need to do to make sure that you actually can do this. So these 4 categories often result in discordance rather than concordance. And that's why we have, these are some of the reasons why we have the challenges that we have with patient adherence. And I know I didn't talk nearly as long as you all wanted me to talk, or at least the agenda said you wanted me to talk. But we have time for a question or two, I think, if people want to do that before we move to our next speaker. What do you think? Questions, comments? Yes? Yes, we have time? Yes. Okay, thanks. Comments, observations? What are we missing here in this model? What shouldn't be in the model that's here? Well, this is what I put together just for this talk. I'm a picture person, so for me to understand, I've got to draw a picture about it. So. You can't. Without a user expense, without a money cost, yes, you can't. Everything costs money, right? I don't know how you do it. It's easy for me to say because when I was in clinical practice, I was a counselor, so I had time. I had, sessions planned, and so I had time to deal with all these phenomena, But if you're a physician in a traditional medical practice, for example, or a PA or a nurse practitioner or whatever, then your time is very much constrained. So you don't have time. That's why this is a model. There's always a little gap between the theory or the conceptual picture and reality. So the question becomes, how do you approximate addressing some of these things in a cost-effective way in the real world where the rubber meets the road, when you don't have but 5 to 10 minutes maybe in an encounter? Doesn't have the time. That's an excellent point. So in a team environment, you have the ability to have a division of labor so some of these things can be addressed. And even if you can't address these things, it's good to at least know that the phenomenon that we're asking people to embrace, adherence, is not something that just happens because we say do it. It's a little bit more complex than that, and there's some attributes that can stand as obstacles or barriers to interfere with that happening in a very perfect kind of way. There was a comment over here. Yes, ma'am. Right. Absolutely. And of course, we have a role in each of these 4 areas as a clinician. The different expectations, the imperfect communication, not invoking the change model the way we need to, and having a different world. So there's a sort of an implicit role, but I think what you're speaking of is something that's more explicit in terms of the role that can actually appear in the model to have some explanatory power in terms of what the role needs to be or isn't. Good point. Dr. Buden Foster.
Thank you, Dr. Lewis, for your talk. I think that's a very important point. And as physicians and nurses, allied health professionals, PT, occupational physical therapists, we have to be aware of our own unconscious biases that we bring to the relationship. We make a lot of assumptions about what patients cannot do, and in doing so, we contribute unknowingly to health disparities by not providing that patient with ART because we don't think they're going to be adherent, or this medication is too expensive, so I'm not going to give it to you. I think the other thing is there's a big literature on physician inertia, that because we're not aware of the guidelines, in particular, let's say for something like diabetes, that diabetes or hypertension, we don't adhere to the guidelines closely enough. So therefore, while it may appear that the patient is not adherent, that may be the case, but because we're not aggressive in adhering to the guidelines and getting patients to target. I think Dr. David Stevens was supposed to be here, but he pioneered a model known as treat to target for hypertension. So that's a great point.
Yeah, and speaking of the bias, of course, as human beings, we all have biases, and one of the things that you should do as a provider is always be in touch with your own biases through a constant process of introspection and being self-aware, and identifying each bias and understanding whether or not it's a bias that's open to change. If so, do whatever it takes to change it. If it's not, come up with a containment plan so it doesn't rear its head in a negative way in a clinical setting, and constantly be doing that all the time. Go ahead, ma'am.
Adding to what was said already in terms of the clinicians and the biases, many times we look at the word adherence, and it may not necessarily be, it could be cultural. And we don't really take that into consideration.
Could be cultural, you said?
Cultural.
Yeah, usually it is. And when we say culture, when I say culture in this setting, I don't mean culture with a big C, meaning race, ethnicity, and those categories that we all think about. I mean culture with a little c, because each one of us has our own unique individual culture. So it's not necessarily those traditional cultural variants, but the fact that any 2 people, even 2 identical twins, who are the 2 people who are the most alike of anybody in the world, have different worldviews and different cultural realities. So, yeah, absolutely. Oh, and actually, I forgot I had a few more pieces. How do I advance this? I'm trying a new thing in my presentations, add a little humor, which I typically don't do. But, yeah, so here we go. Here's an example of the worldview difference. Both individuals are looking at the exact same phenomenon, but because their vantage points or their worldviews are different, they see something very different. Oops. Andy Capp. Remember Andy Capp? Any of us? That sounds like what I would do. So the best thing you can do is give up smoking, drinking, and fried food. So what's the second best? I'm not going to do all that, so what's second best? And so the danger is that it's great if there's a dialogue, explicit, that occurs. But what happens is that the physician says the best thing, and the person like Andy Capp doesn't necessarily, he's thinking it, but doesn't articulate it. And so therein is the problem. If he articulated it, then you could actually have the dialogue could continue, and maybe there's a way to make the adherence more likely. But usually what happens is, what's the second best is just an internal dialogue that's going on that, that you think, okay, well, all right, I'm going to modify that to make it fit what I want to do. And certainly, we become frustrated, but we don't want to do this. I've been here so long, I don't remember what I did, but it had something to do with noncompliance. So we don't want to get to that point. But we feel that way sometimes. That's what we want to do for folks. Okay, that's it. Thank you.
Thank you, Dr. Lewis.